I'm Jenny Branson, and for the last 8 years, I have been the primary music therapist for Norton Healthcare in Louisville, Kentucky. Norton Healthcare is a large corporation throughout Metro Louisville. We operate 5 acute care facilities, 2 outpatient surgical facilities, and dozens of intermediate care centers or urgent care centers in our city. We were proud to be the first medical music therapy provider in our area. So in the Ohio Valley, which we consider our region or our tri-state, it's fairly egocentric there. But we were the first ones to give it a go. And honestly, when I was hired on very part-time. As a new music therapist, I was the first graduate from the equivalency program at the University of Louisville. And they basically just put me in the office and said, go. So I'm going to talk a little bit about what we've done and how we've accomplished it. We haven't been out in the public presenting our work very much because we've been so busy just doing it. We don't have a lot of research published, but I will talk a lot about how we have applied the research that other folks have done in the field of music therapy and in related fields or other allied healthcare professions that have informed our work and allowed us to partner and collaborate and really build an effective program that is fully integrated throughout our system. At Norton Audobon, we are an acute adult care facility. We do no mother-baby, we do no pediatrics, but we can and we do show up in every in and outpatient area of our hospital, which is pretty amazing to me when I consider how we started, and now any one of us can turn up and collaborate. This will be an interactive presentation, so as I go along, if you have questions, feel free to ask, and that will kind of help inform and direct where I go next. I think we can each talk about our work for a long time, but I really want to make sure to answer the questions that you might have about what we do. There we go. A lot of what we did was informed by research, but I have to admit that a lot of it is due to timing. A lot of things that have happened that could only be very subjective, maybe aligning of the planets, perfect timing on our part and on the parts of other people that came together to make these things happen. Our department, which is a music library, opened in 2002, which has been 10 years now. And the actual space and the vision for it was a gift from the widow of Dr. Lerman, who was a pathologist at our facility. He and his entire family received music therapy here in New York at Sloan Kettering. And after he passed away and the family was ready to do something in his memory, that's what they wanted to do. They wanted to make sure that the patients, the staff, and the families at the facility where he had worked for decades could receive music therapy. At the same time, one of our chaplains, who was a musician and who had been a chaplain at an IMF-MR, a facility for adults with profound disabilities for many years, she understood what music could do, and she saw that we had patients that would be in our hospitals for weeks, lonely and deprived from a sensory standpoint. She wanted to have a music library. At that same time, the new program at the University of Louisville was being built, and a music therapist who knew the chaplain and the widow said, you know, you can't have a music library without a music therapist, and I know who you should talk to. So Barbara Wheeler was introduced into the mix. We have a committee, we have a steering committee, and over time, the funds and the energy were put behind this project to open it. The hospital donated the space, and the president at the time, he said, I get what you're trying to do, and I think music therapy is great, but don't ask me to pay for it. So he allowed us to have the space. The Lerman family renovated it. It's a beautiful respite environment for staff and for patients and families. When you walk in, you can tell it's very different from our clinical environment. We had a bank of audio equipment. We had CD players, and we started out with about 500 CDs, just like the public library. Anybody could check out and borrow and bring back. Again, this was the first of its kind in the region, and Norton Healthcare is known for its innovation. They are known for being very evidence-based, for employing the best practice, and for always improving their patient outcomes. They're open to trying just about anything. And the facility where I work, which is on the outskirts of town, the very south end, is typically the place where we pilot things. A lot of our leadership have been there for many, many years. Our nurses have been loyal to that facility for many years, and they've got the kind of teamwork and the kind of vision and the kind of research critique skills that allow us to try things out and determine whether they're effective and whether or not we should take that to our other facilities. As we were building this created a foundation for partnership and collaboration with the program at the University of Louisville. Those of you that are department heads or directors of music therapy departments, you know how difficult it can be in the beginning to find placements for your students and meaningful training opportunities. And this allowed us to have that from the get-go. And Dr. Wheeler would come think it was twice a week for 2 years. She came just to do some demonstration projects. She learned what was important to our facility, what was important to our administrators, and focused just on those projects and providing specific types of intervention in specific areas of the hospital. And we would bring the students, and they were usually senior level practicum students who had the solid music skills and had the solid approaches to music therapy to be able to come into that environment where it's very hectic, where it's very unplanned and unpredictable, and to do this type of work. We collected data each fiscal year, and our fiscal year ends in August, so in August we've got to make our wish list for the budget. So they would have to have enough data and a large enough sample size of whatever they were doing to do this. And these were kind of in-house pilot projects. These weren't IRB regulated. We did this because we were working in the intensive care unit and it was difficult to get informed consent. But the administration was happy to have this happening on site, and to have the data specific to their population and to our city was more important at that time. And this provided great opportunities for the staff to see music therapy. There are a lot of stereotypes about Kentucky, healthcare in Kentucky, and the state of our population, our lifestyles, and a lot of those are very true. And the hospital where I work serves a very outlying demographic. We don't see very many people that actually live in the city. We get the folks that are stat flighted in because they live so far out that even having a heart attack can be fatal because the ambulance can't get to them. And even if the ambulance gets to them, they can't get them to the local hospital in time, or the local hospital doesn't have the means to provide the surgery or the intervention they might need. So we have a large population that is fearful of medical care, that is really fearful of anything considered alternative or complementary. And honestly, a lot of our patients still believe that if they receive music therapy or massage therapy, then we may limit their sedation or their pain medications. So we've really had a large hurdle in getting in the door with the staff and with the patients. But the staff, I will have to admit, have been very patient. They were very open to it and saying, okay, show us what you can do. We'll let you in and we'll let you do this. There are still staff that don't like to work with us, but there are plenty of staff that do and that make great referrals. So the best way for us to teach them was to kind of stand on the unit until we saw that we have a patient who's hysterical or who's failing their weaning trials or who's really struggling with pain management. When we can be the thing or the person that can provide that relief and help that nurse achieve her nursing goals, then we know we've had that teaching moment, that nurse gets it, and suddenly we start getting more referrals. So providing opportunities for them to see the work happening was much more valuable than providing grand rounds, than providing CMEs, and providing written materials on the unit in this situation. The tagline for our department is hope, growth, and transformation. And that came kind of accidentally. When the Lerman family designed my space, they chose these recliners for our space. They have dragonflies all over them, and they're beautiful. And I thought, well, how can we make that work? We've got to have a brand in the facility. You know, our room is purple and green, so all of our materials kind of had that color theme so they would get it, but how can we make use of what we already have? We've got the Norton Inn. Pastoral Care has their logo, so we decided that in most cultures, dragonflies are symbols of hope, growth, and transformation. So that really worked well for us as a department and for our patients who may be undergoing some pretty extensive care and illness. My initial contract was for 20 hours a week, and at the time our facility was 400 beds. We had a lot of semi-private rooms. So to take a brand new music therapist and say, you've got 20 hours a week to show us all how to make this go, it was a little intimidating, but it was a lot of fun. And when I say there was no precedent for us, I mean they took me to my office and dropped me off, and there was a desk and an empty PC, and they said, okay, good luck. We didn't have a referral process. We didn't have referral criteria. I had no forms, no business cards. It was wide open, which I took as a great opportunity. You know, I had read a lot of literature on what programs were doing and what I liked and what I didn't like, but at the same time, it's like, I hope I can pull this off, because there were no medical music therapists near us. There was no one to call. The team that hired me had a lot of phone calls with the Ireland Cancer Center and with DeForia Lane, and we had a lot of those documents. And I got to work really fast, ordering every textbook from every medical music therapy program that had ever been published and collecting all the information we could to find out what's the best way to approach this. But at the same time, keeping in mind that every city has its own culture and every facility has its own culture. And what would work in my facility may not be what's working in Cleveland or in Indianapolis or any places nearby. So the goals for that first year were to educate the staff. What is a music therapist? What do we do? Why do we do it? Why should you use us? One of the best illustrations I have for how they perceived us, which I kind of knew going in just from conversations with my family and in the hometown where I grew up, but they're not going to take us seriously. And one of the nurses, a few years later, she became our best advocate. She said, I really thought you were a bunch of pot-smoking hippies. They just let loose in the building. So we knew that stereotype that we were working against, and we worked hard to kind of tend and befriend and go at it that way. We had to provide bedside interventions. Not only did we have to teach the staff what we do, but you've got to convince the patient to let you in the door. This is a patient who only knows pills. The population we work with, they're very doctor-centered and very pill-dependent. We had to collect data. That I knew how to do. Anyone who's worked with Barbara Wheeler or read her work, you know how to collect data, so that wasn't a problem. I was asked to provide clinical supervision to students from my very first semester. That was hard. The good thing about it was the student I was supervising had been one of my cohorts in school, so we could kind of supervise one another, really, because she was not far behind me, and I trusted her to be honest and to do the work that she was asked to do. Manage a library. I was given this music library, and I was given a volunteer who worked about 20 hours a week. She was fantastic and organized, but are you familiar with the Hallmark character Maxine? That's the personality I had. So she was very effective, but I was not to alter anything that she had set up. So I have a library, and it's not cataloged in any way that I would ever have dreamed of, but it works, and we've kept it that way. It started out with about 500 recordings. We now have about 3,000. So we had to manage the library, which meant I had to figure out what's the best way to check equipment out, track it through the building, get it back, sanitize it, and get it ready to go again with 400 beds. So that was an interesting logistics thing to learn how to do. And fundraising. Our initial project was grant funded for the first 2 years. Most grants for music therapy typically lean towards research or some type of publishing opportunity, things like that. We were asked not to do that at first, but we had to be able to sustain ourselves long enough to demonstrate the efficacy of music therapy and to make it go. We had a steering committee. We still have them. They're not as active as they were, but we did a series of fundraising concerts. We started out 1 per year, and then we would go to 4 a year, art auctions and different things to help raise awareness and funds for our jobs. And to expand my contract for 2005. So from the very first day, my job was to make my job bigger. So that was the first year. And now we're going to talk a little bit about the growth, about where we are now, and then I'm going to come back to how we did this. At Norton Audobon, we now provide about 100 hours of therapy per week, and that's board-certified music therapists. This does not count the interns or the students that come to work with us every week. We have about 20 hours of an assistant who helps manage the library and do our clerical things and our visiting artist program, and we have about 20 hours of volunteers who take care of the library part, managing the equipment and the iPod program that we have. We provide services in all of our in- and outpatient areas. This includes pulmonary rehab, cardiac rehab, wound care, hyperbaric wound care in the outpatient setting, the Neuroscience Institute for rehabilitation. We just started doing cardiac CT because we know that when patients are having this type of procedure, their heart rate has to be below a certain threshold before we can do the CT. So rather than administer more drugs or make them wait, they will page us directly to the room, and we will work with them and kind of get that over with. And when we say co-treatment and consultation, the co-treatment is typically co-treating with physical therapy. So we will co-treat for patients that have had a neurologic injury, for patients that are anxious, patients that have pulmonary disorders and can't regulate their breathing with the movement to provide those cues. We co-treat with speech therapy. And we are starting this year to co-treat a lot with wound care. Our facility provides a lot of care to people with chronic, often lifestyle-related illnesses. The typical hospital stay for an adult in an acute care facility is 3 to 5 days. It's not unusual for our folks to be there for 8 weeks. They come in with one thing, and because of the comorbidities and just complication after complication, they move all over the building. So we have had patients there for weeks and months. They may leave for a few days and come right back with another complication. So we do a lot of co-treatment because if you've had one nasty dressing change, you are not looking forward to the next one. To keep the anxiety and the pain management in check, and also to teach relaxation techniques so that they can self-regulate beyond the music therapy experience. we say consultation, we're actually talking about music therapy intervention. We say consultation in our facility because the nurse have to put in a request for a consultation, and that means we show up and we do whatever needs to be done. I was looking back at our statistics because it's time to give our administration the statistics and talk to them about how much we do and how much more we need to do. And we had more than 2,300 referrals for individual music therapy in the last year, and that's bedside one-on-one. This doesn't include any of our outpatient or groups. Last year we averaged about 45 referrals a week. This January, we've had a huge shift in the patients that are admitted. We're doing more than 60 referrals a week in the inpatient side. The music library services are still available. We've got about 30 CD players. We have the CDs, and we do iPods for music and surgery. Patients can opt to have their preferred music throughout their time in surgery in the recovery room. We can also provide perioperative music therapy in the prep and hold area and in the recovery room to ease that transition back to the unit. We do clinical training, supervision, and collaboration with the University of Louisville and their bachelor's program. The University of Kentucky just opened their master's in music therapy program this month, so we anticipate a lot of collaboration and research with them. And when we are doing clinical research, we are doing it in collaboration with these two universities. They take care of a lot of the IRB paperwork and things like that for us so that we can continue the actual work of music therapy. A lot of community outreach. We do outpatient groups, which are really important. We do a lot of education, so we go to nursing schools, physical therapy schools, to the U of L School of Medicine to do lectures on what music therapy is and how you should work with it. Observation and shadowing opportunities for other students or other disciplines. We often get nurses who request to shadow us because they're like, we'd like to have this at our hospital, but I need to know how to describe it and how to get it there. And education support, continuing medical education for our physicians and our nurses, for social workers. Co-treatment opportunities, which is a great way for our other allied healthcare professionals to learn about what we do and to experience it for their patients. Research collaboration and guest lectures. So we're out in our community quite a bit. We probably do 2 outside presentations or interactions every month, in addition to the work we're doing. Another component of our program that's been in place since I was hired, but it's really only taken off in the last 2 years just because of the resources we have available, is what we call arts in healthcare. One of the visions that our administration had was that we would have performing artists coming in to volunteer their time in the public spaces of our hospital. As a musician, I understand how hard it is for them to receive that request to come and work for free for 2 or 4 hours every month. But we have gradually built that. We have a lot of performers in our area who are interested in working in a healthcare facility. They aren't sure how to get started, things like this. This provides them an opportunity to have a low pressure performance practice opportunity to be in a healthcare setting and give back to their community without crossing the boundaries of what may be appropriate for a volunteer in a facility or not wading into something they're not prepared to deal with, especially in the facility where we are because the patients are so sick. I can't imagine what it might be like for a classically trained musician who's never seen a body in this condition to walk into a room and expect to know how to interact with this person or how to process what they've just witnessed. So we have Arts at Audubon. We recruit our own volunteers, and we recruit artists who have art exhibits in our library space. The staff are accustomed to having our exhibits, and they come by quite often to have a break from their work and to enjoy the art, to sit in the recliners, to have quiet, sometimes to have music. And we have now, the week before I came here, a formal partnership with Kentucky Center for the Arts. Several years ago, they had done the training through the Johnson & Johnson Society for the Arts and Healthcare Arts and Healing project. And they were really gung-ho about getting all these artists and dancers and musicians out at the bedside. And they had approached us and we said, you can come, but you can only be in our public spaces. For so many reasons, we can't allow you at the bedside. So they refused to work with us initially. And we had what we would call a mole in the program. One of our music therapists is a juried musician for the state of Kentucky. She said, I'm going to go and see what this is about, make sure they're not doing anything unethical, and also be a resource for them because these artists and musicians will need some debriefing and some support when they come out of these facilities. They were going into some of our more intensive inpatient psychiatric facilities, into some of our burn units and things like that. And she was exactly right. Within the first 6 months, those artists and musicians were like, oh, we have such a better experience when we go to facilities where there are arts therapists because they choose the patients that are appropriate to participate with us. And so over time they saw what was happening. They now have a new director who was a music therapy student with us at one time, and she called us and she said, we just need to do this. I need to find some money in my budget to partner with you. And I said, well, do you mean Norton Healthcare? Because we can spread you throughout the 5 facilities. She said, no, we're only coming to Audubon. So we're really blessed that they see the value in that type of supervision and in that type of collaboration. So we will have a minimum of 1 visit every month from their music, art, and dance artists that will come to our facilities, working primarily with our outpatients who have chronic illness. Before I go on to how we did this, do you have any questions? Okay. So the transformation took place very gradually. It was in fits and starts, and sometimes we have leaps. And the joke in our office now is, well, we would like to do this new initiative, but what if it works? Where are we going to get the staffing to do this? We all started out with this grant funding, kind of as seed money to get our projects going. We now have 10 music therapy positions throughout our system. All of our positions are in the operational budgets of their facilities, which is really great and really scary, because if they start looking really closely at the budget numbers, we don't generate income. Right now in the state of Kentucky, there's no third-party reimbursement for music therapy services. When I was hired, one of the goals I did not put on there was that my job was to find out how to bill and get insurance reimbursement. I had worked as an insurance billing clerk in a former life, so I knew how to do that, and I was dreading it. And I met with our CFO, and he said, we use a per diem rate for adults in acute care, and here's what that looks like, and we're not going to be able to carve out something specific for music therapy, and we know that this population is not going to pay extra for this service. He said, moreover, it will cost us more to pay the person to do the research on these billing codes than it does to pay you just to be here. So just go, do your work. So that was fantastic. Part of that, the caveat there is the patient satisfaction scores, which I will get to shortly. The way we did this was through relationship building and networking. We stay on top of the current research in music therapy, in medical music therapy, sometimes in pediatric music therapy, because that informs some of the work that we do. I've learned that when folks are sick, they're really all 3-year-olds, and they respond to the same things. So a lot of the work that I do in the intensive care unit was informed by the work done in the NICU around the country. So formal networking looks like going to meetings and being on committees and teaching nurses and doctors and being a part of new processes and standing order sets in our facility. I'm actually housed under nursing administration, and my supervisor is the director of quality. So she is always looking for the best practice, what's going to improve patient satisfaction scores, what will improve patient safety, and what will improve HCAHPS. Has anyone had to start looking at HCAHPS in their facility, the healthcare quality? That's a huge deal, and by 2014, we all have to answer to that in order to receive reimbursement for the services we provide in our facilities. So she has her ear to the ground. She knows what's important to our president, she knows what's important to our network, and I rely heavily on her to tell us where should our focus be. I know what I think would be really great to do, but what's going to further the mission of this system and of this facility and of my department and the nurses that work here. The informal networking looks like we do our charting on the unit next to the nurses so they see that we're charting. When we go get coffee, we go to another unit and stand around and drink our coffee with those nurses. How are your kids doing? How's your mom? And just being a human being in the trenches with those nurses. We make a lot of referrals and provide a lot of information and resources to our staff that work there. Hey, where can I find a great guitar teacher for my kid who has dyslexia? We know where to find that. Or I need a musician for my mom's funeral. And it's much more meaningful for them to have someone they know and for one of us to provide that. We have to have a working knowledge of our roles and, more importantly, others' roles. I had to go in and learn, how does this machine work? How do all these moving parts operate? And how can I be not underfoot, but be helpful and to do this? So it changed some of the ways I approached intervention and the way I present intervention. And, we all know how great music therapy is, but they have no idea. And the most important way to show them was to just get in there and be a partner in achieving the patient's goals. We actually have open access or open referral to our services, and we've had that from day one. Anyone can request a music therapy consultation for a patient. Some of our best consults come from housekeeping because they actually spend the longest amount of time in a patient's room, cleaning that room. all they have to do is wave us down, put a Post-it note on our cart, they can send it through the computer, they can make a phone call, they can slip it under our door. And that has taken down so many barriers. We don't have to wait for a physician's order, we don't have to get anyone's okay, because one thing I learned was that if nurses have to do one more thing, they might implode. So we just want to make it as easy as possible. And we provide support in any capacity to our staff, to our families, and to our patients. Clinical intervention is a given. That's what we do. Personal support, if we see a staff person really having a bad day, part of our job is to provide that support, some basic kind of counseling intervention there in the hallway, take them back to the office, let them decompress, make the referral to employee assistance if we need to, make the referral to pastoral care if we need to. Administrative support, we get in there and do the projects with our facilities just like everyone else. We have this huge Christmas party at our facility for the community. We're there stuffing gift bags, we're providing carolers, we're a part of the team. And creative support. Sometimes it takes someone who's not trained in a linear fashion to look at a process and say, oh, well, I see where the bug is. I know, let's do this, a more real world thing. And then going back to the research, we've talked about that a little bit. We actually get a lot of articles slid under our door from nurses and physicians, and they'll write a note like, can we try this? Or, this doesn't make sense, why are they doing this? And then that opens the door for a conversation. Right now I'm having a heated debate, this has been going for about 5 years, with one of our anesthesiologists, why we don't just provide Baroque music. That's it, everyone should get Baroque music. So, it's been an interesting challenge for me. In my position to kind of argue that diplomatically. Oops. I don't know. I can't see what's at the bottom, so we'll go on. Visibility is a huge part of our effort. I wore my jacket today because this is typically what we wear. The first few years we were working in our facility, the big deal was, no, we're not wearing a white jacket, and we're not wearing scrubs, because I don't want my patients to be afraid of me. Even a patient with dementia or who's sedated on the ventilator, when they wake up and they see that white coat, panic. Also, I look terrible in scrubs, so I really didn't want to wear those. But as the population changed and our patients became more ill, and we began to treat patients from other healthcare systems who had hospital-acquired infections that were really scary, we were kind of wading into icky stuff. And it's not uncommon for us to be right there at the bedside, and things happen. And my dry cleaning bill was just enormous. So we tried this out just to see how it would go. And this washes so much better than some of my dress clothes. And it was amazing the difference it made. Because I wear my name tag every day. People don't read your name tag. And I realize a lot of my patients can't. They're older, they don't have their glasses because they sent them home so they wouldn't lose them. They're not gonna look at that, but they see this. They see this big M for Norton Healthcare, and they know that we belong there. When I was wearing my dress casual clothes, I realized the only two populations in our hospital that wore those were administration and pastoral care. So they thought that we were either an administrator in there to do something, we're the chaplain, and where we are, patients assume that if the chaplain's there, it's because you're dying. So that created some panic. Or that we were part of a music ministry. So this allows us to be functional, to appear clinical as we are, and also to have something that's functional for us to work and live in as we move back and forth through the facilities. We appear on every unit every day. We go to bed huddle every morning where the leadership to get together to talk about staffing needs, but also that's when the nurse managers will say, oh, room so-and-so is really struggling, this family's really struggling, and we get a lot of referrals that way. We document the same electronic medical record system as our nurses, and we were present when we built that system, and I got to build our own screens, which sounds like a great privilege, but it was awful, and I don't want to do that ever again. But it helped me to see how are the nurses thinking and working, and how do we play into that. So we actually have some pop-ups. When nurses do pain scores, it'll pop up and say, do you need to call music therapy or pastoral care? So we were able to build that in from the ground up. We have one-on-one follow-up with our referral source. We'll go back and say, I saw so-and-so, here's what happened, here's what I recommend. We have brochures and materials printed all over the building, and we have missed consult cards. Patients are often asleep when we stop by, or they're out of the room. So we have these big neon-colored cards that say, sorry I missed you, you were referred by, and we leave that. We've already talked about committees, task forces, and the projects, and the staff education. We have a lot of publicity, in our community through presentations and observation, but also we make an effort to have at least one appearance in local media every year, whether it's a newscast or a newspaper or magazine. And we try to have that in March when there's Creative Arts Therapies Week. And we have a lot of events surrounding that in our hospitals and with the Kentucky Center for the Arts, just to generate more publicity about that. And this is the last piece I'll talk about. We're okay. Joanne had asked me to talk a little bit about program structure, because everybody's program is built a little differently. And ours is a matrix, which is this really confusing grid of little squares and lines. And I really didn't feel like that's how we interacted. So this was the best representation I could find. My title is actually Matrix Coordinator. I don't supervise all of our therapists, but I coordinate them. We come up with all the policies and procedures that we use. We help inform their goals and their evaluations, because usually we are supervised by people who are not music therapists and they don't know what to expect. So I was afraid to use this because I thought, well, I'm not the center of the universe, but I was using it because the edges kind of overlap. So we are each supervised by different directors in our facilities, whether it's service excellence, quality, rehabilitation, or the Cancer Institute. We interact with the 2 universities in our state, the Norton Healthcare Foundation, which funds our special projects and our growth initiatives. They work with us to pay for travel when we go to do consulting, different things like that. We have to interact with our library and arts volunteers, 9 music therapists throughout the system, and we have a media tech. His name is Norman, and he's fabulous. And his job is just kind of keep us running, answer the phone, keep the iPods loaded and charged, and to be a host for the families. Our office is between open heart and intensive care. We find a lot of very upset and frustrated families in those hallways, and he's wonderful at bringing them in, offering the nice Kleenex, glass of water, and a recliner, and kind of just letting them know that we're available and that we're there. So that's kind of the end of what I had to talk about with program structure. But do you have any questions? Bedside is live. We do have recorded music available, and that's usually loaned out to patients who are bored, who are cognitively intact and aware enough to turn a CD player on and off and to use that intentionally. So I would say 99% of what we do is live music therapy. One more.
I have a question about the use of the patient's preferred music during surgery.
Right.
When you're getting input from doctors, how it is for them to be listening to the patient's music opposed to what they would prefer. I'm wondering for myself, I would rather that the doctor was listening to what he or she would want to listen to.
Our patients actually receive their own iPod. So they have their preferred music, and then the doctors can listen to whatever they like over that. So yeah, we have encountered that question quite a bit. So thank you.